This program is brought to you by Emory University.
Welcome to Emory Cardiology Echo Lecture Series. It is my pleasure to introduce Dr. Patrick Gleason. Dr. Gleason is the Director of Structural Imaging Program at Emory, and today he will talk to us about TE evaluation. Thank you, Patrick.
All right, hey everyone. My name is Patrick Gleason, as Özlem said there. Let me go back here. I do most of the structural imaging for the structural heart and valve program here at Emory, which is based at Midtown. So I'm going to talk about basics of transesophageal echo today. So this is mostly geared towards some of the first year cardiology fellows. So some basic stuff here, but hopefully some useful tips and tricks even for people that are maybe a little bit further along in their training as well. So disclosure is that I've trained on and primarily used Philips echo equipment. So, you know, there's obviously a lot of other vendors out there, and some of this information that I'll share with you is specific to the Philips echo machine, and so does not apply necessarily to, let's say, Siemens or GE, something like that. So TEE, transesophageal echocardiogram. I think what's important to remember about this technology is that it's the same basic echo principles that you're using with transthoracic. You should get better image quality because you're closer to the source. You get to use higher frequency, but same things will matter in terms of optimizing your scan to make sure that you get a good diagnostic scan, right? So patient position and comfort, good windows, and then small movements with the probe, as one of my predecessors, I would say micro movements, right? So if you're doing a transthoracic echocardiogram on a patient, you've all had the experience where just small movements can make a big difference in the terms in terms of the echo quality picture that you're getting. And so same thing applies here. You know, I see a lot of fellows, you know, making big movements, going in and out, and moving the probe around a lot when that's usually not what's going to help optimize your picture. So so I've got kind of a 5-step program here that we'll go through in terms of how you perform a TEE, screening and consenting a patient, getting them ready for it. Once you get the probe down, performing the study, and then, you know, getting them all through. So let's go through this and stop me at any point if you guys have questions. So things to keep in mind: how to maximize your chances of having a good quality diagnostic TEE. Prepare everyone, the team, the nurse, the techs, the patient, that it's going to be a long study. Most of the time it doesn't take 30 or 40 minutes. That's more for a structural TEE, but it's good to set the expectation early. Patient must be adequately sedated. I know that there's some attendings that like to use less anesthesia for their cases. You're going to have a tough case, right? It's going to be a battle. The patient's going to kind of be thrashing around. So important to use things like the big wheel and the small wheel when you're doing it. Again, these small movements. Make sure you're taking enough pictures. No points taken off for taking too many pictures. And then I'll say it again, patient positioning is very, very, very important. All right. So screening, we have our indications for the procedure. Most common reasons that you're going to see will obviously be bacteremia, endocarditis evaluation, obviously arrhythmia and planned cardioversions, as well as stroke evaluation, and then structural heart procedures. You know, what different valvular disorders or structural heart issues, you know, will patients have that require further evaluation. But in general, you know, use common sense. Is the procedure appropriate? Will it affect management? As a kind of guiding principle of whether or not you should proceed in doing the procedure. So I'm getting, all right. So screening, we've got a question here. So a 52-year-old woman with insulin-dependent diabetes, PAD with lower extremity amputations, CKD, is admitted with sepsis and bacteremia. You're halfway through the exam when the patient starts to vomit large amounts of gastric content. You check the chart and see the MPA order was correctly placed the day before. What's the most likely reason for the patient vomiting during the exam? Patient eating and drinking the night before, too large of a meal, or diabetic gastroparesis? Anyone want to hazard a guess? Yeah, so this patient, and this has happened to me a couple of times, this patient has diabetic gastroparesis, and started, and this can happen. This happens, like I said, this happened to me a couple of weeks ago. So it's important to pay attention to these types of things when you get patients. Obviously, being MPO for this procedure is important because they run the risk of vomiting. But for your patients with diabetic gastroparesis, maybe even longer than like a 6 to 8 hour window, and maybe a 12-hour window is more appropriate. So let's see next. All right, 87-year-old gentleman with a history of esophageal strictures admitted for a TIA. His lower extremity weakness has resolved, but neurology would like to get a TE. Due to dysphagia, he requires an EGD before the TE. After his EGD, the gastroenterologist calls you up and tells you that they dilated his mid to distal esophagus with a 15-millimeter balloon. Is it okay to proceed with the TE? All right, I'm gonna start calling on people. Bruno, what do you think? Okay to proceed, yes or no? All right. Bruno's gone to sleep. Fair enough. So it is probably okay to proceed, although, so the tip of the TE probe on a Phillips is 17 millimeters wide. We just had this on a patient, and they used a 54 French like tube to dilate the patient's esophagus. So they can normally go up to 20 millimeters on their balloons for EGD. So just important to clarify that with the gastroenterologist before you partake in this, so that they know that that's the size of the probe, and that's how far they kind of have to dilate up. Next here. So getting into patient screening and absolute contraindications, I think some of this makes kind of common sense, but gotta state it, right? So uncorrected esophageal strictures or mass, you don't want to put a large probe down there. Active upper GI bleeding varices or ulcers, also not a good idea. And then esophagectomy or fistula, can't put a probe down. I've highlighted the ones that are a little bit more common. So relative contraindications, stable or corrected varices. If someone hasn't had an EGD in a couple of years, probably a good idea to have gastroenterology check them out again. Sometimes they need to band them or things like that. Coagulopathy is on here. We do a lot of TEs on patients that are taking anticoagulation, right? If they have AFib or some other arrhythmia, and we're going to need to cardiovert them. An INR of less than 3, 2 to 3 is fine, and NOACs are certainly fine. You get into questions, if someone's INR is 6, is it okay to proceed? You're going to really increase your risk for causing esophageal trauma with elevated INR. So unless it's an emergency, you're doing a ascending aortic dissection evaluation or something, probably best to wait on people if their INR is significantly high. And then patients that have a gastric bypass, esophageal only views, may be smart. Other things that aren't specifically listed in the guidelines would be something like chronic steroid use. In fact, the only esophageal perforation that I've ever heard of was was from a former fellow who was doing a TE on a patient with rheumatoid arthritis, chronic high steroid use, and actually perforated. So, things like loose teeth, gastroparesis, which we've talked about, anemia with benzocaine spray, which we'll talk about here in a little bit, and then stroke mainly just because patients may have difficulty protecting their airway. And so you may need to kind of have anesthesia on board or around if you're going to do moderate sedation. All right, so probe, probably important to know a little bit about it and what it can do, and size. Again, the tip of the probe, again, this, can you guys see my pointer? I don't know, I think you guys might all be muted.
We can see it.
You can see it, okay. So the tip of the probe down here, 17 millimeters wide at its widest. This initial I guess the very tip of it is not flexible. It's rigid and stiff. And then up until this kind of secondary point is where all the direction can come from, right? So you can anaflex it or retroflex it, kind of move it to the left or to the right. In those cases, if you haven't done it before, I would play around with these, the direction knobs here. So the light gray wheel anaflexes and retroflexes it. Understand how that's going to move the probe inside the patient's esophagus. Anaflexing the probe is going to obviously bring in anterior structures. Retroflexing it will bring in posterior structures. And then right and left can kind of clean it up. There's this silver key on the back that can lock this tip into place. So you can either make it where there's no rigidity to it at all. And that's if it gets turned all the way, I guess, to the left, our left here, if you're looking at it. And then it can be a rigid tube if it turns all the way to the right here. Again, there's 3 knobs. You can kind of do it all the way loose, kind of in an intermediate phase, and then in a completely rigid. I would recommend never using the rigid one. I don't know exactly why you would use that, just because you're going to increase your risk of esophageal trauma there. Consenting the patients, what do you tell them as you're doing the procedure? The risk of a serious injury, meaning mostly perforation from TE, is extremely rare. So you can tell them less than 0.1% of cases. Something like, knocking out a tooth, some sort of oral pharyngeal or esophageal abrasion where they have a little bit of dysphagia. In a routine TE, still would be less than 1% of patients. For a structural heart procedure, that's a different story. When we're doing something for a mitral clip or, one of these prolonged procedures, there's actually a paper that recently just came out in JACC that looked at this, and they did EGDs on all these patients before they did their TE, and then they went ahead and did an EGD afterward. And about 40% of people, they had what they described as complex lesion, and as many as 86% of them had some sort of injury, even if it was a superficial soft tissue injury. So that probably has a lot to do with long procedure time, a lot of probe manipulation, and then all of our patients are anticoagulated during the procedure. So we target ACTs of over 300. So you've got a procedure that's 3, 4, 5 hours long, and you're moving the probe around the entire time with really high ACT levels. We're going to end up with some injury. Interesting though, in all these cases, no long-term injury. People had about 10 to 15% of people had severe kind of dysphagia, which resolved without any sort of intervention, and no untoward outcomes because of it. So, all right. So we got down patient screening and consent, pretty straightforward for that. So let's go in step 2. We've got patient preparation. All right. Next question. You're preparing a patient for a TE. You start moderate. Before starting moderate sedation, you give the patient 2 viscous lidocaines to gargle. You're called away to see a patient in the ER. You come back 20 minutes later and give the patient another 2 viscous lidocaines to gargle to make sure that they are still numb. You're called away again, this time to see a patient in the CCU, and return one more time and give the patient 1 more viscous lidocaine to make sure that they are numb, 100%. As you're getting ready to start, the patient becomes unresponsive and starts to convulse. What is the most likely cause of this patient's current state? Who's got something? Arnav, Marcelo, what do you think?
Is it hypoglycemia?
Didn't hear you there. Can you?
Is it hypoglycemia?
No, so this person is actually having seizures from lidocaine.
Oh.
So seizures and altered mental status is a potential side effect of lidocaine, and this, believe it or not, actually happened at one of our teaching hospitals here at Emory not long ago when I was a fellow. And so this is a real thing, and it can happen, and it happened to someone here. So long story short is obviously, you never need to use that much viscous lidocaine, one, maybe two lidocaines is completely sufficient in order to numb up the back of their throat. You can have them gargle for a long period of time, but definitely a dangerous side effect and one that you got to pay attention for. All right, next question here. You're preparing a patient for TE and give one viscous lidocaine to gargle after swallowing. Test their gag reflex, which is still strong. So you spray benzocaine in the back of their throat for about 10 seconds. Coat it nice and evenly. As you're getting ready to start, the O2 sats start to drop rapidly. There's no wheezing on exam, and the patient is breathing comfortably. You call a code MET, grab an ABG, which is pictured right here. So what's going on?
Methemoglobinemia.
Yes. So this patient has methemoglobinemia, and this is an ABG from a fellow here on a TE done within the past 6 months. So it's a chocolate brown color, undeniable, right? This is clearly not a normal ABG here. And so, so let's talk about what we can do for anesthesia for these patients, right? So we have topical anesthetics, lidocaine and benzocaine. We have MAC, which is what we use at Midtown mostly. So anesthesiologists help us. They use propofol or ketamine. And then moderate sedation, which is what most other places use. And we use a combination of fentanyl and Versed. Again, the important thing is that the patient should be comfortable, right? And not really struggling when we're trying to do the exam. I know that's sometimes challenging, and most of the fellows don't have control over that. But as you get out in practice, you'll feel like that's important. So lidocaine, as we talked about, can be a dangerous thing in the right situation. So these normally come in 15 to 20 millimeter containers. You should have the patient gargle one of these containers for at least 60 seconds, and then they can swallow it. You can use a second one if absolutely necessary. If you go on and look up lidocaine and potential side effects, seizures, as we've already demonstrated, can be one of the side effects, but it also lists methemoglobinemia. And what probably is more likely the case than the lidocaine itself is that there's some sort of it kind of acts as a primer, so to speak, and potentiates the effects of benzocaine. So let's say if you have the right patient who has anemia and some sort of pulmonary disease, and you use a lot of lidocaine and then you use a lot of benzocaine, then you're probably a setup for methemoglobinemia. So, in general, if you can avoid use of benzocaine, I would. If you need to use it, very, very short spray, 1 or 2 seconds, just target in the really back of the oropharynx, and that's it. But obviously, the big concern is methemoglobinemia. So, what is that? We got to talk about it because it happens, unfortunately. So, oxidized hemoglobin does not bind oxygen, right? That's our main problem. So the patients, you're going to see their sats start to drop. Certainly, once they get below 85, you start to become really concerned that that's what's going on. They get kind of bluish, brownish color. So you obviously have the clinical history of these people, and then you get an ABG and the color, as we already showed. And the methemoglobin level will probably be much higher than 5%, but that would be at least the diagnostic threshold, right? So risk factors include anemia, lung disease, and then active systemic infection. So these patients that have sepsis and the hemoglobin of 6 are set up for this. Treatment is with methylene blue, 1 to 2 milligrams per kilogram, given over 5 minutes. The one thing that you do have to watch out for with methylene blue is that it can precipitate serotonin syndrome, interestingly enough. So watch out for it in patients that are on SSRIs. All right. Okay. Patient prep and positioning, getting into patient positioning. I can't tell you how many times I walk into a room to do a TE with patients and the fellows have them set up like this. So appreciate John Lisco for modeling correct patient position here. But this here on the left, please make sure they're scooted up in the bed. Usually if they're, butt is back in the crease and they're sat up at like a 45 to 60 degree angle, that's going to make it a lot easier for you having the patient swallow and getting the probe down, getting good pictures. If they can get in the left lateral decubitus position, then you're going to end up with good pictures, and it'll be easy. Sometimes it's a little bit harder to get the probe down. Certainly, if you're using moderate sedation, you need them to swallow. That's kind of a tough situation. So, so more likely they'll be sitting up, but you can put a couple of pillows under their right shoulder and usually get them into position that you need to. All right, and then lastly, some of the basic things that most of you know, but we got to go over. MPO at least for 6 hours, 8+ hours is preferred. Again, maybe for some of our patients, even longer. IV access, you got to have O2 and end-tidal CO2 monitoring, suction, and then your reversal agents on hand. All right, so we're almost through halfway through there. Okay. Probe intubation, we're not going to spend a lot of time on this, but bottom line is highest risk for injury during TE. So don't force the probe down. It should slide down smoothly. If you're doing moderate sedation, the probe should go back, just past the tongue. And then as you're asking the patient to swallow, you advance the probe as they're swallowing. Again, when they're under MAC, it's a lot easier, but usually the anesthesiologist or someone will help you with the jaw thrust and it'll kind of slide down. There's always this concern about, if you're having trouble, do you put your fingers in the patient's mouth? I would not put your fingers in their mouth unless they've got a mouth guard or a bite guard in there. Have had a couple of situations over the years where people have, gotten bitten and things like that. So, but most of the time you can still fit a finger in there if you've got the bite guard in. So I highly recommend that. All right, so perform the study. So, the biggest things I can emphasize for performing a study is first of all, having a systematic approach to how you're going to do it. So, some attendings have their own way, and maybe that'll help you inform how you're going to do, your TEs in the future. If they don't, come up with your own way and follow that each time. It'll help you make sure you don't miss anything. Typically I do a mid-esophageal view. I get all my valves. Then we go appendage, pulmonary veins, inner atrial septum, and then we go in transgastric, get, transgastric and deep gastric, and then we come out and we run the aorta. So, so here, one of the things that I want to point out, and this is going to seem very obvious in one way, but something that I didn't think about early on when I was learning TEE is that, you have to image through the left atrium when you're doing a TEE. And so the better you can be positioned behind the left atrium, like this picture here, with the green arrow, the better your pictures are going to be. Here is a situation in the bottom with the red arrow where we're kind of on the side of the left atrium. And sometimes this is unavoidable, right? The person's heart is rotated. They have a hiatal hernia, all sorts of reasons why we have bad pictures. But one of the things I would always try to do is if you see this, you may be advanced too far. And so one of the things you can do is try to pull out and retroflex. And sometimes you'll end up kind of snapping back into this position. Sometimes not, but oftentimes you'll kind of clean things up by withdrawing the probe a little bit and retroflexing, and you can kind of get this good position right behind the left atrium. And that gives you a better view into all these structures that you're going to have to view rather than kind of looking at it sideways, which we know with these ultrasound beams, the better we can have these direct planes, directly at a structure and directly back, the clearer our picture is going to be and more diagnostic. So here's just a rundown of what I would consider just doing kind of a basic diagnostic TEE here. So, we'll run through these things. Again, most of you have already done a lot of these. And so this is a little bit, one of the things that, there's a lot of studies that I see that will, they'll just go through once you get into a 4-chamber, you go 0, 30, 60, 90, 120 degrees around the mitral valve. I'm not really sure where that came from. It has nothing to do with the anatomy. I think it's totally fine if you're doing a endocarditis or a bacteremia study and you're just trying to go through and get a number of different, angles on the mitral valve to look at it, but it really has no bearing on the anatomy. And I would encourage you not to just try to go to straight angles, but to pay attention to anatomy and follow that more than direct angles. So let's look at what that may look like, right? So here, good 4-chamber view, positioned directly behind the left atrium. In most cases, you're going to need to retroflex. So things that you can assess on a good 4-chamber view: chamber size and function, valve function, most cases, pericardial effusion, right? So both the mitral valve as well as the tricuspid valve. Let's go next here. All right, so one of the things that got to point out, when you are just doing a straight 4-chamber and you are at 0 degrees, just like we were here, you can image different parts of the mitral valve depending on how far you are advanced and whether or not you're anaflex or you're retroflex. So, this is kind of if these thick black lines are the echo beam here, this second image kind of corresponds to this middle line here. And if you withdraw the probe, you can see that your line would move from here to here. You bring in the aortic valve, which is over here. Sometimes if you anaflex, you can get the same effect, but you're now imaging kind of P1, P2, whereas if you go from this image here and you advance a little bit, you're looking more at A2, P2. And if you advance even further, kind of in a A3, P3 maybe type of thing. So there you've kind of panned through the entire mitral valve without even changing your angle. You've just kind of moved the probe a little bit out. You find the aortic valve and then advance in, and you're able to kind of pan through the entire mitral valve in that situation. Obviously, you can flip over and look at the tricuspid valve there as well. Same concept though. Probe, is still at 0 degrees. If you pull out and advance in, you'll start to see different parts of the tricuspid valve that kind of lead you to a different part of the valve. All right, this kind of, I just threw this in here because I think it illustrates that point. So with this here on the right, whoever is doing this TEE is not advancing the probe at all. They're simply going from a very anteflexed view and to a very retroflex view. So if you think where they start out, the probe is anaflex, so you're going to see anterior structures. Those include the appendage, the aortic valve, and as you retroflex, you're going to go and see more posterior structures, the mitral valve, the tricuspid valve. So a lot you can change without again making big movements to the probe. Next, we'll talk about our commissural. Sometimes you'll hear this being called your trapdoor view. You should see P1, A2, P3 here, and this is a good example here in the upper right-hand corner. So you have your appendage here, and you can see a little schematic of it right here. This is essentially how your beam is cutting across these. So you cut across P1, A2, and P3. And so A2 is what's dropping out of the middle there. You can see both of your papillary muscles that are coming up and attaching here. And these are your commissures, your medial commissure and your lateral commissure. The lateral commissure is by your appendage. Again, P1, A2, P3. But it's important. You can see on this person, it was at 43 degrees, and on this person, it was at 73 degrees. So not necessarily at one of our predefined, 0, 30, 60 kind of things, something that you're going to have to look for a little bit more. And again, find that anatomy, find that trapdoor view. If you're ever, wondering if you're in the right place or if you have the right view, you can always X-plane off of here. And this should give you a nice A2P2 view. You're at your anterior and posterior leaflet. Again, you're X-planing, you should see your aortic valve that you're going through here. So something to just kind of let you know that you're in the right place. 2-chamber view. This is less important for the anatomical factors for the mitral valve leaflet. You cut through a large portion of the mitral valve leaflet here, and P3 is actually more important for the walls. You kind of isolate the anterior wall and the inferior wall when you're doing this. So something where you can maybe assess wall motion abnormalities a little bit better on TE, which can be challenging. All right, 3-chamber view. Now we're sending our beam right down the middle. So right down A2, P2. Again, you can see the aortic valve here. This patient is up at 160. Again, not necessarily at our 120 view. And then you can pan through the valve, right? So I've got a little scheme here. So if you clock, meaning that you're gonna turn it to the right, you're gonna go medial on the valve. You can see how that would kind of wave the valve over to the medial segment, which is over here, versus countering, which is gonna send it laterally towards your appendage, all right? Numbering the leaflet scallops starts at the appendage, A1, P1, going medially 2 and then 3. Your interatrial septum would be over here on the right. So let me ask, how do we know that, how do I know that I'm at A2, P2 here in this bottom left picture and not medial or lateral on the valve right now? Anyone have any idea? Fair enough. So the reason that we know that we're at A2, P2 and not medial or lateral is because we don't see any papillary muscles. There's no papillary muscles here, so we know that we're in the middle of the valve and cutting it right down the middle, as you can see in this upper screen. If we were in one of the commissures, you know, you would see a papillary muscle and a bunch of cords. And so that's how we know we're nice and centered at A2, P2. It's also good to evaluate aortic valve, obviously long axis of the aortic valve, X-plane off the aortic valve so you can get a short axis. Let's see. Usually from that 3-chamber view, we'll jump into a 3D mitral. So this is a little bit confusing because it kind of flips your 2D picture around, but we go into this 3D surgeon's view. So this is what a surgeon looks when a surgeon goes to do a mitral valve surgery and they cut into the left atrium. This is what they see. They see the aortic valve up top, the anterior leaflet right here up top, and then the posterior leaflet on the bottom. The appendage is over on the left. The interatrial septum is on the right. Again, numbering 1, 2, 3, going left to right. And so we can get very nice, obviously, 3D pictures here, both with and without color, that kind of give us an idea of anatomy and what's going on. From there, most of the time you drop your angle down, center up your aortic valve, and then you're able to both assess your aortic valve, the pulmonic valve down here, and your tricuspid valve for morphology, endocarditis, you know, regurgitation, stenosis, all the above. Here we're just showing how the tricuspid can be evaluated, the pulmonary artery, both in long and short axis. And then usually from this inflow-outflow, we'll get a tricuspid valve in 3D as well. The easiest way to orient this is a little bit different than how we oriented the mitral valve. So in the mitral valve, we had the aortic valve at 12 o'clock. In the tricuspid, we like to put the aortic valve over kind of somewhere near 9 o'clock. And what that does is help us orient the septal leaflet on the bottom. Then we have an anterior leaflet and a posterior leaflet. So the anterior septal commissure for the tricuspid valve is right near the aortic valve. So that's how we kind of help direct us to where that's going to be. The posterior septal commissure is where the coronary sinus comes in. So those are some landmarks that help us kind of orient to where we are and what we're looking at. As you can see, this patient actually has dynamic TR here. This is, you know, on respiration, you can see that coaptation gap gets worse. All right, next you're going to want to assess the appendage. Most of the time, you can do this from any view that you've already had in the mid-esophageal view. You can go to 0, you can go all the way up. The more important thing is that you're going to have to anaflex a little bit on the probe, right? Withdraw slightly, and if you're still not seeing it, then you kind of, you know, keep anaflexing and keep withdrawing. Most important thing is just make sure you go all the way through 0. You can go up to 180 if you want, but 0 to 135 should be sufficient for you to get a good look. at the entire appendage. A lot of people will pulse wave the appendage. Low flows, certainly less than 20 milliseconds, is associated with stroke or higher risk of thromboembolic events. The clinical utility of that and whether or not you'd start someone on anticoagulation, I think is questionable, but regardless, a lot of people will do that. The important thing to do is if you're going to take a pulse wave, make sure that you're far enough into the appendage. You want it to be 1 to 2 centimeters into the appendage to get an accurate velocity there. What you'll see a lot on a lot of these patients that are going for cardioversion of things, you'll see this smoke or spontaneous echo contrast. That is slow flow, sluggish flow. You may even see it more prominent in the tip of it. There may even be a thrombus or some sludge here at the tip of this leaflet here, or you can see frank, obviously, thrombus that is kind of collected in the left atrial appendage. Obviously would be important for anyone, let alone our stroke patients. All right, so next we talk about evaluation of our inner atrial septum. So we typically will do that in 2 views. One is in a bicaval view. So I'm gonna go ahead and pause this here. So we have our SVC to the right and our IVC to the left. So, and then in our other views, we have a short axis where we have our aortic valve here. So what this does is gives you some sort of idea of where the defects may be. So, SVC, we call those superior defects on the inner atrial septum, and the IVC, those would be inferior defects. Similarly with the aortic valve, we have anterior defects of the septum and posterior defects, so things that are away from the septum. When you're doing a stroke evaluation, you see here the difference in the Nyquist limits. So here it's 61, and we've turned it down here to 30. A lot of these PFOs, they're going to have slower flow. And so turning down that Nyquist limit is going to help kind of bring out any flow across that PFO if you have anything. Things to remember, if you do see something, always measure kind of the dimensions of whatever hole is there, right? So if it's a PFO, we want to measure how long the tunnel is, how big it is. ASD similarly, what are the dimensions? How big is the hole? What are our rims around it? Is there going to be enough tissue to attach a closure device? Here are a couple of examples of, so here's a PFO on a patient with a really long tunnel. So we would measure this whole tunnel. That would help inform, what kind of device we would end up using to close in the end. Here's a secundum ASD. You can see it kind of coming in and out. And what's important again for these ASDs is that we get, how much time do I have left? Okay, I'm running out of time here. But, that we see how much tissue is left around the aortic valve or posterior to it, that if we're going to try to attach a device, that we're able to do that. Pulmonary vein evaluation, important for our mitral regurgitation. It does help. I should have included here with understanding kind of left atrial pressure, and it can also be important in our congenital heart disease evaluation. So 2 easiest ways to find them. If you're in a bicaval view, you'll clock over and push in a little bit, and you should normally see the right upper, certainly the right upper pulmonary vein. If you keep clocking and pushing in, you can see the right lower pulmonary vein. There are some other ways to do it, but that's kind of the easiest way. And then for the left upper pulmonary vein, again, probably the other easiest one to check out is usually right behind the left atrial appendage. So you can, whenever you find the appendage, withdraw the probe a little bit and counterclock, and you should usually be able to see it. If you want to see the left upper and left inferior, the easiest way I've usually been able to find it is you find the appendage at 135, and then you continue to counter over, and they'll come in there right behind the appendage. Same principles for grading velocities in here, 1 to 2 centimeters into the vein when you're going to measure them. Okay, transgastric view. So you're going to advance the probe into the stomach. Do not push past any resistance. So if you are not able to pass the probe past the GE junction, do not keep pushing, because it's in most cases not worth it. But so you get into the stomach and you anaflex, and you know, depending on how firmly you anaflex, you can get either the apex, the middle, or the base of the heart. One of the things that I found to be easiest, you know, most of the time people get a short axis and then they'll go up to 90 degrees and get a long axis. But, you know, one of the easier things to do is just get a long axis and X-plane off of that. And you kind of get a complete evaluation of your LV function, which is oftentimes pretty difficult on a TE, but this may be the easiest way to do it. So long axis, X-plane off the apex, you can kind of see the short axis function, X-plane through the mid and the base as well. And you get a really good sense of regional wall motion abnormality and LVEF. Next, that I would recommend you practice with a lot, because a lot of fellows don't understand the tricuspid valve at all. So once you go from a LV long axis view, and you just clock over from there, you should see a tricuspid valve, right? So kind of a tricuspid valve inflow, RV outflow view here. If you X-plane off of the leaflet tips here, the tricuspid valve, you will see probably the only place that you can find a good representation of all the leaflets here. So we have a septal leaflet here near the interventricular septum, we have the anterior leaflet and the posterior leaflet. And you obviously can get a great look at anatomy and see leaflet function here, put color on and see exactly where how bad the color, how bad the regurgitation is and where the color is coming from. And then deep gastric, aortic, so you would advance the probe a little bit, anaflex more, and you can actually get a deep gastric looking at the aortic valve and the aorta. And do a complete hemodynamic study of the aortic valve. So get a stroke volume, mean gradient, or even pressure halftime if there's severe AI. The aorta, you'll at that point, after doing the deep gastric, you'll kind of withdraw the probe back into the mid-esophagus, counterclock over to the C of the aorta. Seeing it in two planes, both in a short axis and a long axis, I think is helpful in understanding, you know, pathology and if there's any dissection or kind of complicated atheroma that you're going to see there. You can see that once you get high up into the arch, one of the things that you'll obviously will tip you off. You'll see the subclavian that comes off there, and then you can kind of counter and follow the arch down. I think that's it. I'll give you a couple examples here of endocarditis that I think kind of illustrates some important concepts, and then I think we'll finish up so you guys can get on with your day. But so again, endocarditis is going to be one of the main reasons you guys are asked to do these TEs. And in some cases, you know, you'll see a discrete, you know, vegetation on a leaflet. One of the things that's important to always kind of check for once you see a vegetation or you see that there's valve destruction is to start looking, particularly in the aortic space, is do they have involvement of the annulus? So you can see here in this view on the left that the integrity of the aortic root here has been disrupted, and there's maybe a little fluid pouch here, and you can see that there's flow through some of these areas. So this person has an annular abscess as well, and you can see it in the short axis as well. At times it kind of comes in and out. You can see the little pocket there that has kind of been created by the infection on the aortic valve. It's very important for the surgeons to know, you know, once these people are on antibiotics and, you know, they're not bacteremic anymore, going in there, kind of what operation they're getting themselves into. Here is a huge mitral annular abscess that we had on a patient. Obviously, there's been complete destruction of this leaflet and part of the annulus. So, all right. So you're all finished up now. You remove the probe. I would check the probe for blood every time you remove it, just to make sure that there hasn't been any kind of issues there. And then the patient needs to be monitored, make sure they can eat or drink something before they leave. Usually that's about an hour or two after the procedure and all of the lidocaine and benzocaine have worn off. So last things, again, just to reiterate, maximize your chances of having a diagnostic quality TEE. Prepare everyone that it's going to be a long study. Please sedate the patients. Use the big wheel and small wheel. Take plenty of pictures, and then patient positioning. So I think that's it. We got some common pitfalls. Again, this is mostly these are involved with the probe being too far advanced into the esophagus and trying to image from there. In most cases, again, withdrawing and trying to retroflex a little bit will correct most of these problems that I see on some TEs that are maybe a little bit non-diagnostic. Sometimes, again, it may be patient position. If the patient is scrunched down in bed and they're bending at the, at their stomach and the diaphragms are up and they're pushing the heart over, it may be hard to see the picture. And so getting the patient scooted up, leaning them over to the left, some of these things can make a huge difference in your image quality. Is there anything else? The references, check out the comprehensive TE guide. It's really long. It's not a light read, but there's also a University of Toronto website that's very useful and takes you through the different images and some of the tips and tricks. I think that's it. Özlem, do you have anything else or anyone else have questions?
That was perfect, Patrick. Thank you.
The preceding program is copyrighted by Emory University.